afternoon, everyone. Thank you for attending today. We are just going to give it a couple more minutes to allow others to enter into the meeting. And so, yeah, we'll get started very soon. Thank you.
All right. Good afternoon, everyone. For the record, my name is Erica McAllister, and I am the School Health Services Liaison for the Nevada Health Authority and a MAC and BAC support staff member with the Community and Provider Engagement Team. Welcome. Thank you for being here. On behalf of the Nevada Medicaid Advisory Committee, I would like to call the meeting to order and verify that this meeting is being recorded.
Yes.
Okay, thank you. Today's meeting agenda for the Medicaid Advisory Committee was posted on July 11th and revised on August 5th, 2025 at dhcfp.nv.gov and at notice.nv.gov. I also want to take the opportunity to introduce some of our other MAC support staff members and some people from our executive leadership team. We have Dr. Melinda Southard.
Hi, everyone. Melinda Southard. I serve as a Deputy Director here at the Nevada Health Authority for Community Engagement and Workforce Development. And so happy to be here with you all.
All right, thank you. And just as a reminder, if you need to use the restrooms, just out this door to the left and then it will be straight ahead. And then in the case of an emergency, we would be taking the exit that you came through in the front door. Next, I will pass it on to Jonathan.
Hi, good afternoon, everyone. For the record, my name is Jonathan Figueroa. I am the Community Engagement Specialist and a MAC and BAC support staff member. I'm going to go through roll call to confirm if we quorum or not. When you hear your name, please respond with here or present to confirm your attendance. Bill Sims. Here. Israela Gravel.
Here.
Grace Larkins.
Present.
Kehlani Queen. Ann Jensen,
Present.
John Phoenix,
That's okay, we can keep.
Don Lyons, Dr. Todd Gray,
I'm sorry, I couldn't get to my mute button. This is Dawn Lyons.
thank you, Don. Dr. Todd Gray, Sharon Austin Moffett, Dr. Desiree Gomez, Casey
I'm
Melvin, thank you.
Present.
Shauna DeRose,
Here.
David Eskime, Kim Kahagan,
Here.
Nicole King,
Here.
Dr. Rahul Mediwala. Here. Sarah Dearborn,
Present.
Robert Thompson,
Here.
Ricky Robb,
Present.
Marla McDade Williams.
And I'm present.
Thank you all. Quorum has been met. Next, we'll move on to public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Person making comment will be asked to begin by stating their name for the record and to spell their last name and provide mschiffer@nvha.nv.gov with written comments. Comments must be provided up to and including the day of the meeting by 5 p.m. for inclusion on the record. If you would like to provide public comment, please raise your hand in the Teams app or type public comment in the chat along with your name so you can be called on to begin. If you are joining the meeting by phone, you can raise your hand by pressing *5 on your keypad. When we call on you, we will identify you by the last 4 digits of your phone number. When you are called on, please state your first and last name at the beginning for recording purposes. You will have 3 minutes to speak. I will now pause to see if there's any public comment. Seeing that there's no public comment, we'll move on to the next item. We'll be moving on to agenda item number 5, starting with committee member introductions, and then moving on to agenda item number 4. I will call out the names of our new members. When I call on you, please share a few words about yourself and let us know which council committee you are representing. Bill?
Hi, Bill Sims for the record. I'm just your average video gamer who actually has a very unique talent that I can pop both my wrists out. And it sounds gnarly when you listen to it. And I'm here for the Medicaid Advisory Council.
Thank you. Azraela?
I'm Azraela. I have a Master's of Public Health and Epidemiology, a Master's of Science in Management Organization. I am on the Medicaid Advisory Council, and I have 3 lovely children.
Kehlani?
Hello, my name is Kehlani Queen. I am a Vegas local. I've been out here since the late 90s. I am also a mom of 2 and a Medicaid doula and also a licensed DNA. And I've worked with hospice patients and assisted living patients that receive Medicaid and Medicare benefits.
I believe John was.
Yes.
Don?
Hi, I'm Dawn Lyons. I am the Executive Director of the Nevada Statewide Independent Living Council, and which is a council made up of a majority of people with disabilities.
And move on to Sharon?
She's also absent.
Dr. Raul Mediwala.
Yeah, Rahul Mediwala. I'm a nephrologist by training. Came to Reno in 2008, and over that period of time, I've seen a lot of growth in the area. I have also an administrative role at the Renown Medical Group. I lead the Renown Medical Group as well. Thank you.
Casey.
Hi, my name's Casey Melvin. I'm an occupational therapist based out of Las Vegas, and I run Tilton's Therapy and Tilton's Therapy for Tots as their CEO. Provide multidisciplinary practice for occupational, physical, and speech therapy services statewide.
Thank you. Dr. Desiree Gomez.
Hi, I'm Dr. Gomez. I've been a pharmacist for over about 20 years in Las Vegas. I have twins, they're older now, and I just wanted to make a difference for people in the Valley. And I precept for the students at the pharmacy school here. And I really love my career, and I'm here for the Medicaid Advisory Council.
David.
Who's also absent.
Hi there. Hi, I'm sorry. I guess that I received the invitation to participate, but I wrote back and said I'm actually with one of the health plans, and it might have been a mistake. So hoping to get some clarification on the role.
Hi, David. I did send you an email. I did send you an email, but maybe we can touch base after this. But all of our managed care organizations will have a representative to serve on this committee. This is not
okay.
Yes.
Okay.
So thank you for being here.
Absolutely. I actually have a meeting that starts in 16 minutes because I didn't think, but we do have some other Anthem people on the call.
Okay. Should we have him designate one as a designee for this meeting?
Yeah, that'd be great.
Can you give me a name of who could be the, I guess, designee for Anthem for this meeting?
Yeah. Yes, our Chief of Staff, Brooke Greenlee, is on the call.
Okay. Perfect. Thank you. That is helpful.
Yeah, I apologize. Thank you.
That is okay. Thank you. Yeah, can we have Brooke introduce herself? Sorry. Brooke Greenlee, do you mind introducing yourself for Anthem?
Oh, hi, everyone. I'm present. Brooke Greenlee, Chief of Staff from Anthem Nevada Medicaid Plan.
Thank you.
No problem.
Kim.
Hi, good afternoon. Kim Gahagan. I am the Associate Vice President of Growth and Community Engagement for Molina Healthcare of Nevada. I'm excited to be a part of this because I live in this community as well in Las Vegas, and want to hear from recipients and the comments and suggestions that they have to make improvements.
Thank you.
Nicole.
Hi, my name is Nicole King. I'm the Vice President of Government and Community Relations for Silver Summit Health Plan. So I oversee all of our housing, justice, community health workers, community investment, marketing, and government relations. Really happy to be here. Thank you for including us.
And
yeah.
Yeah,
We made it past summer vibes.
Yeah.
Hello, everyone. Paul, can you hear us? Okay. Sorry, I think we're having technical difficulties. Okay. Okay. We ran to get an IT staff in case it happens again, but hopefully not. So, sorry, Anne, do you mind introducing
Sure,
yourself?
happy to. Yeah, Ann Jensen. I'm the administrator here at Nevada Medicaid and really excited to be here.
Sarah?
My name is Sarah Dearborn. I'm the chief over our medical, dental, and behavioral health benefits coverage for Nevada Medicaid. So really excited to be here. Thank you for the opportunity. I believe I'm an ex officio member, so not technically a voting member, but happy to engage in conversation and talk about all the benefits that Medicaid beneficiaries are able to receive.
Robert?
Good afternoon. My name is Robert Thompson. I'm the administrator for the Division of Social Services. I am a native Nevadan. I was born and raised in Las Vegas. I'm a dad and a granddad and thrilled to be here to support this. And I'm here for the Medicaid Advisory Committee.
Ricky?
Good afternoon, everyone. I'm Ricky Rubb. I'm the administrator for Aging and Disability Services. I'm very grateful to be a part of this and see how we can navigate services for all Nevadans. I am a mom of two. I too am a native Nevadan. I represent the northern part of the state, and I have two wonderful boys, one of which is getting married on Saturday. So now I finally get a girl too. Did we lose you guys again? I think we lost you guys again.
Sorry. Yes, sorry, everyone. We're trying to get it fixed.
Yes, I seem to have an unstable connection. I'm popping on and off.
Okay. That is really odd. We are trying to get that fixed, but please bear with us as, we navigate this. And okay, hopefully it doesn't happen again. If it does, just, we'll take a little pause when that does happen. Sorry to do that. Marla, do you mind introducing yourself?
Good afternoon, Marla McDade Williams. I serve as the administrator for the Division of Child and Family Services. We oversee child welfare in Nevada, including foster care and adoption, as well as juvenile justice services and certain children's mental health, inpatient and outpatient. I serve in the role as an ex officio member for the Division of Child and Family Services.
Thank you, Marla.
Yeah, thank you all for those introductions. I'll now pass it off to our Medicaid Administrator, Ann.
Okay. Oh, I didn't introduce. I don't know.
Oh my gosh, yes.
Yes.
Yeah.
Unless am I not supposed to?
No, you are. Yeah, thank you. Yeah, please go ahead. Yeah.
Did I stay long or am I supposed to be on the?
I believe you are on here. So
Okay.
yeah.
Okay. Maybe we just
missed
make
you. Yeah. Sorry, we have one more introduction. Grace Larkins.
Hi there. I'm Grace Larkins. I am also on the Beneficiary Advisory Council as the mother of a 10-year-old daughter who has complex medical needs. And so she is a recipient of the Katie Beckett eligibility option. I also work at the Nevada Center for Excellence in Disabilities at the Family Navigation Network, working with other families who have kiddos with complex.
Thank you. And apologies.
Awesome. All right. Well, thank you all. I'm thrilled for you to be here. I want to thank those that are taking time out of, I know, very busy schedules and family obligations to be here. I know for those of us up in North, it's first week of school back. So thank you for taking the time to be here. And for those that are also part of our back this morning, we appreciate you hanging in for the full day. I will ask your patience as we will go through some of similar content on our Medicaid 101, but hopefully the acronyms make even more sense this time. So I really do appreciate it. So for the purpose of today, really excited, our MAC support staff asked me to give a bit of an overview of what the Medicaid program is. I'm sure this is familiar to most of you, but I do think it's really helpful to take a step back and think about kind of at a 10,000 foot view, what are we doing and how does that fit within the national context and within the state context? What type of program are we running here? So I will be running through this and attempting to use as few acronyms and funky Medicaid words as possible. But if you are confused or have any questions, please don't hesitate to interrupt anytime. And with that, let's move to the next slide. So overall, Medicaid actually just celebrated its 60th birthday nationally, just about 2 weeks ago. Medicaid was established as part of Title 19 of the Social Security Act. So President Lyndon B. Johnson signed it into law. 2 years later, the Nevada specific Medicaid program was launched. So the way Medicaid works in all 50 states and the 6 territories of the United States is it's a state and federal blended program. So the state laws really, or the federal laws really undergird everything that we do. And then the states have optional choices to modify that and to choose how they fund it in conjunction. So I'll be walking through a lot more details here about how does that funding work? How do those streams kind of align? What do benefits look like? And how do recipients receive care? So we'll talk about the delivery systems at play here as well. So if you move to the next slide. Before we dive into the policy details, I think it's important to think about who do we serve and what does this look like right now? So the map on the right, of course, shows our state. Dark blue shows the highest concentration of recipients. 78% of those live in Clark County, and you'll see up Washoe County region, particularly Reno and Carson, represents the second highest portion. But we truly have recipients in every corner of our state. And to run a statewide program, as I've spent a lot of time driving through the state since I moved here, really means running at least 3 different types of programs, right? One that works for Clark County recipients, one that works for Reno and Carson, and then one that works in our rural and particularly our frontier counties as well. So I think we take that very seriously, that this program is statewide, and that really requires a lot of creativity to meet the geography of our population. Right now, 1 in 3 Nevadans are covered by Medicaid. That's about 800,000 people. That has grown fairly significantly since COVID and now has leveled out because of some policy changes and that related to the COVID and the transition out of the public health emergency. 1 in 2 births in the state are covered by Medicaid. So the portion of our recipients that are youth is much higher. So you'll see that reflected in our population as well. And that means that there's a lot of money being spent on healthcare for recipients. Right now, it's $5 billion in spending every 2 years. So the state budget's on a biennial basis. And that $5 billion represents both the state and federal money at play. And we'll talk about what that looks like on the next slide. We're going to spend a lot of time today talking about a couple key questions, one of them being, what is the delivery system? Meaning, what is the mechanism that patients receive care and providers receive compensation for delivering services to Medicaid recipients? Right now, about 3/4 of people receive their care through a managed care plan. We'll talk about what that means, and we'll talk about some changes that are coming in that world. But you'll really see our population is representative of a lot of different groups. Medicaid very intentionally is designed to serve a range of recipients' needs, and we see each one of those recipient types reflected in our population. And so really thinking through the ways that we can develop a program that works best for kids and for adults without children and for people living with disabilities, right? All of those folks are reflected in our population here. Any questions on kind of the demographics, who we serve, what our recipient population looks like overall? Or any surprises maybe for folks that are seeing this for the first time or second time today? I think Bill called out earlier, the dually eligible population is an important one. It's about 86,000 people receive both Medicaid and Medicare coverage. It's a really interesting and complicated alignment of 2 really big federal programs. And so there's a lot we can do to really support those folks benefiting from those programs appropriately.
As for Ella here, 66% are employed, but also enrolled in Medicaid. That's impressive.
Mm-hmm. Mm-hmm. Absolutely. No comments. No comments in the chat. All right, we'll keep moving. So we're going to talk about a little bit more. How does the federal policy work for Medicaid? So if you move to the next slide, as I mentioned, it's a federal and state blended program, meaning for every dollar that is spent in Medicaid, there's 2 different inputs, one from the federal government and one from the state of Nevada. So that blue federal share bubble should be typically a little bit bigger than that green bubble. And that's because in the state of Nevada, about 60 cents of every dollar comes from the federal government for our services. And that breakdown, the size of those bubbles, is different for every recipient group. So the federal government determines how much relatively the federal or state share is of payment for those particular patients. And that looks different in every state. And it's based on the economic outlook of that particular state. So some states, the federal government covers over 80% of those services. In other states, it's 50-50 because that state has a lot more economic resources. So Nevada's about average there, with an average of 60% federal share, 40% state share. And that 40% state share really comes from the general fund, which is what we'll talk about through the legislative process. So if you move to the next slide, in order to get the money in that blue bubble, in order to get that federal funding, there's a lot of really complex regulations and rules that we need to follow. So our director, Stacey Weeks, has this fun visual that I think is a really helpful way to think through all those components. And I'll recognize there's a lot of wonky policy terms here, and we'll go into detail on what these actually mean in subsequent slides. But the foundation of all of this, that flower pot, looks the same in all 50 states and 6 territories. That's because it's Title 19 of the Social Security Act. It's the regulations that the federal government sets for every Medicaid program. There are base requirements for who is covered and what benefits are covered and how those are paid for that we can't deviate from. That's a condition of participating in the Medicaid program. But there's a lot of choices that we can make that reflect the state-specific options. So the STEM, what grows from that pot, is really the Nevada-specific version of the program. And so we have a contract with CMS, which is called our state plan. We'll talk about that in a second, and it's a fun acronym. But that is really the way that we define what the Nevada Medicaid program looks like. And our state plan is unique to us. It looks vastly different than the state plan for California across the border, or Utah, or Oregon. And that's because it's defined by the state-specific choices. It's watered, that plant is watered by the things that we choose, the optional benefits we add, the things that our legislature or our governor select to include as part of the Medicaid program and budget. And what results from that, if you want to hit next, and you can see my very fun animation that I forgot was there. There we go, is our flower. So our Nevada-specific program is really what grows from all of that. And we document that in what we call our policy manual. It's in our contracts with the managed care organizations, as well as our federal waivers with CMS, where we ask for Nevada-specific exceptions to federal regulations to design the program that we want. So it's a really complicated way these all come together. Each flower looks very different in every state. So I want to spend some time talking about what that Nevada-specific model looks like. So if you move to the next slide, the important question, and one area that states get to decide about their Medicaid programs, is how care is delivered. And what that means, we were talking about this in the back this morning. The way I like to describe this question is it's really about whose name is on your insurance card, right? Who is the entity that's paying the provider for those services and is responsible for managing your care? There's 2 different flavors of this in Medicaid, and every state, the balance of those things looks different. Some states are entirely fee-for-service, meaning the state directly runs the Medicaid program. So the state is the one directly handling payments with providers and enrollment. They also determine how much providers are paid for the services, and it's a very direct state-run model. In Nevada, this represents about 25% of our recipients right now. These are recipients in our rural counties, as well as populations with special healthcare needs that are not part of our managed care program. The other option is what we call our managed Medicaid program. And that's when Medicaid, the state of Nevada, goes into a contract with a health insurance company like Anthem or United or Molina to provide care to recipients through what's called a managed care contract. And the intention of that is really to provide care coordination. We talked a lot about that this morning as well, to help our patients navigate the system and ensure they have access to the care that they need, and particularly access to preventative services, chronic disease management, and really help figure out the right way to essentially navigate what we all know is a very complex healthcare system. So the managed care organizations are then the ones that create networks with providers, enter into contracts with them. They set the payment rates based on our requirements, and they generally navigate the program. Importantly, the flower pot and the flower stem, all those state plan items that Nevada chooses, the Medicaid managed care organizations are held to those 2. Those base requirements are consistent no matter what delivery system you're in. The kind of optional extras are what looks different in the different plans. So what's important is right now, our managed care program is available in Washoe County and Clark County. On January 1st of this year, and we'll talk a lot more about this shortly, and I'm excited to get feedback from this group, we're moving to what we're calling statewide managed care, meaning every single county in the state will have a managed care product available to patients. There are still recipients that will not be part of managed care. Those include folks with more complex health needs or folks on our disability waiver programs, as well as our tribal members have an opportunity to opt out. But generally, we expect the number to go from 75% to closer to 85 or 90% of recipients in managed care by January of this year. So that's a significant transition, and we're going to talk about that in our next section and how to get feedback from you all on the right way to do it, both from the recipient perspective. We had some great discussion about how do we notify people that their plans may be changing and what does that look like, but also for our providers in our rural communities, this is a big shift. And so this is one of our top priorities over the coming months, and we're really excited to get feedback from this group. Any questions on care delivery systems here? Okay. Let's keep moving. So state plan, this is the stem of the flower diagram that I talked about. What's important here is this is our formal written kind of legal agreement between the state and the federal government, the Center for Medicare and Medicaid Services, CMS, that really dictate this is how Nevada is running our Medicaid program. If it doesn't exist in our state plan, we can't do it. We can't receive funding for it. So this is really the foundation of our work. It tells us who's eligible for Medicaid, how much do we pay for services, what services do we pay for, what providers can enroll with us. All of those details are in our state plan. So any change that we want to make needs to go through what we call a state plan amendment process, or a SPA. What's really important is that this is a long process that involves internal work to really think about what edits do we need to make, how do we define this. We then bring it to our community stakeholders and we give their feedback and we ask for input on the right way to do this work. And so I'm really excited for the MAC and BAC to provide input on our SPAs as well as we seek to really make these modifications to the program. At that point, we then submit the SPA to CMS. And then it's in their hands. So there's often a lot of back and forth with them to clarify the intent of the change. Sarah can really speak to this. Some are approved really quickly without questions, and it can go within a few months. Other times it takes up to 2 years for a SPA to be approved if it's complicated. And so this is a really core component of our work, and that our benefits team really leads to make sure that we can have a state plan that reflects all those Nevada choices and our Nevada specific program, which is great. So if you move to the next slide. What's in our state plan? The other key question besides who's delivering the care is what care does Medicaid pay for? And we use the word benefits to really mean what are medical services, dental services, behavioral health services, pharmacy services that Medicaid will pay a provider to deliver to someone who's enrolled in Medicaid. So Title 19 of the Social Security Act includes mandatory benefits. This is the flower pot, right? There's no negotiation. Every single state includes these benefits. You'll see a lot of very familiar things reflected and maybe some surprises, but generally these are kind of the basics, or what was considered to be part of the basics in 1965 for a Medicaid program. If you move to the next slide, these are the benefits that are allowed to be paid for within Medicaid, meaning the federal government will pay for them if the state chooses, but it's optional. The state has to make that selection and request that through a state plan amendment. So there are things on here that may strike you as a surprise. For me, I know prescription drugs is one that is always a surprise, right? That's not actually required that Medicaid programs cover any sort of pharmacy services. I think nearly all of them do. I don't know any that do not right now. But that's part of reflective of what's in a federal regulation, right? In 1965, perhaps that felt like less of a priority, and now we all know that's going to be really crucial. So you may be wondering, what does Nevada's list look like, right? So if you move to the next slide, in the green box is what our benefits that we've selected to cover are. This is not fully comprehensive, it's more general categories, but it should be things that our recipients on the call are very familiar with, and our providers, of course, are as well. These are really core services that are delivered at no cost to all Medicaid recipients. Things that are not covered include cosmetic surgery, experimental treatments, alternative therapies. I will call out dental is a big change. That's an optional benefit in the federal requirements for adults. It's required for kids, optional for adults. Our Medicaid leadership included that in our Medicaid budget request. We really decided it was a priority for us to cover adult dental services, particularly preventative services and cleanings for adults. And we received legislative approval to seek federal approval now to cover that as an optional benefit. So really excited for that to move from the orange box to the green box very soon once we get that federal approval. Any questions on the benefit side of things or what is or isn't on this list? Okay. Great. Let's keep moving. So I know this isn't a lot of talking at, so I appreciate your guys' patience. These are my last 2 slides. But I think what's really important is to think about, now that we have a little context for what we're doing in Medicaid world, how is the Medicaid program designed? What is the purpose of this committee? And it's really intended to advise us on how we design that flower, right? The way that grows should reflect the needs and voices of our community. And that includes recipients and it includes providers, as well as other community advocates, our managed care partners. All of us play a role in designing what our state Medicaid program looks like and how it evolves in time. So the purpose of this group is really to give feedback and suggest ways to improve Medicaid, as well as just facilitate more communication. We really believe that stakeholder engagement and feedback on our work is crucial to all of this. This is not the first time we're getting feedback from folks on our state plan amendments or our policies. I hope that many of you have experienced joining our public workshops and hearings on those very topics. But we believe that we need to have a really dedicated space to have these conversations at a higher level and to really have a sounding board for a lot of the big changes that are happening. And we view this group as a really crucial way to do it. So if you move to the next slide, as we've mentioned, there is also kicked off this morning a beneficiary advisory council. This is very similar, but it's made up exclusively of recipients of Nevada Medicaid or their families and supporters. So the way that these two work together, if you move to the next slide, is we have back members representing here on our MAC, which I'm super appreciative of. This is a marathon day of meetings for them and they're having to hear me talk all day. But what's really important is that our back members are able to bring some of that discussion and learnings from the morning conversations to this broader group that includes even more stakeholders in this process. So that is the way we envision them working together. Again, this is a process that every state and all 6 territories across the US are launching right now as well. So we're all trying to learn from each other and figure out the right way to do it and the right way that works for our state here in Nevada. So I'm really excited and appreciative of you all taking the time to do it and bearing with us as we figure it out. If you have feedback on topics we cover, we're going to pick your brain all afternoon, but there's certain things that you'd like us to include or to cover in this forum. We'd be really eager to hear it because we want this to really serve you all as well. So with that, I will pause. Questions? Anything about the Medicaid program, Nevada Medicaid, what we're doing here and why?
Any questions from the online folks?
If I have described Medicaid without any questions, that would be my biggest win of the day. So I'm sure there's things that are unclear. So please don't hesitate to ask.
I have a question. My name is Tina. I'm with Safe Harbor Medical. I know there's other Medicaid dollars that go into social services, and will we be discussing those as well?
Sorry, Tina. Unfortunately, we cannot take any comment from the public unless we're in a public comment period, but we will definitely take your question later on in the meeting when we do have that public comment period. Thank you.
Yeah, happy to answer that then. That's a good question. Any others?
Any other questions from committee members?
One potential question. How often so I get the flower pot analogy, which is excellent, right? The basic title or 19 is not changing, but how often are there programmatic changes? Is that always yearly or could there be programmatic changes in the middle of the year?
Yeah, it's a great question. So if you want to actually go to that flower pot slide, I really focus on Title 19 there, but the way that the federal government supplements those is through regulations that are put out by CMS. So kind of rulemaking where they can issue guidance and say, here's the new requirements of the program that all states must meet. There's also things called state health official letters or show letters that get sent out. That's more informal guidance that's shared, and that can happen at any time. So there's a lot of guidance that's going out right now, and will be going out regarding HR 1, the budget bill that passed, regarding how to interpret federal law within the Medicaid program. So I would say the flower pot, while it's consistent in all 50 states, it's consistently changing and they're repainting it all the time. So those things do happen very quickly, and we have a whole team that closely monitors those changes and helps us make sure we're aligning with those. That's a great question. Yes. Mm-hmm. All right. Okay, great. So if anything comes to you regarding the Medicaid program, again, acronyms, words that we use, please don't hesitate to ask. This is a very complicated world. I know I learn something new every single day still. So there's things that you're curious about. I'm sure someone else is also wondering. So please don't hesitate to ask. So next on the agenda related to the appointment of the chair and vice chair. So as part of our committee structure, we will have a chair that really works closely with our MAC support staff and will guide the agenda and discussion questions and really navigate the meeting itself moving forward. So that chair will be supported by a vice chair who can step in when they're unavailable, and they'll kind of work as partners throughout this process. And so typically those are filled through a nomination process. And we know today is the first meeting of this group. And so what we'd like to do is really introduce these two roles and ask you all to consider a nomination either of yourself or someone else on the committee. We'd like you to send those to us within 2 weeks to our community and provider email address, which we will make sure all of you guys have after this meeting. Once we'll gather those, we'll follow up with next steps for the group to make a consensus selection. And that chair and vice chair will be selected at our meeting in November. So anything you want to add on the chair and vice chair side, or any questions from the group on what those roles will look like off the bat?
No, I think the biggest thing is that, like Anne said, we will bring the nominations to the next meeting and vote on those selections. So
cool.
I'm sorry.
Any questions?
Heidi,
Yeah.
This is Monica. I'm sorry to interrupt. The chair and vice chair are director appointed, so we will not be voting. Those are director appointed. I apologize.
Thank you, Monica, for correcting me.
Thank you.
I appreciate it, Monica. Great. So yes, again, nominations. Please don't hesitate to nominate yourself if you're interested. Truly, we appreciate your willingness to spend that extra time, and we'd be excited to work with you. So send those over in the next 2 weeks, and we'll make sure you have that email. And with that, we'll head into the administrator's report.
Yes.
All right.
And before we start, this next agenda item is, we're wanting it to be more of a discussion. We do want to keep in mind those that are attending virtually. If you do want to jump in at any time, please feel free to unmute yourself, or raising your hand maybe works best. And that way it'll pop up on our screen and we can call on you. And then I'll be kind of taking notes. We did this during our Beneficiary Advisory Council meeting earlier today, and kind of took some notes on some of the discussion topics that we discussed. And yeah, so please feel free to jump in, and I'll pass it back over to Anne.
Awesome. Thanks, Ivy. All right, so 3 things that I'm really excited to bring to this group today that are kind of some of the top 3 that we're really focused on as a Medicaid division right now. And those are, number 1, implementation of the Nevada legislative session and bill activity, and after that ended in June. Number 2 is that transition to statewide managed care. So as I mentioned earlier, that January 1st planning. And then the third one is our children's behavioral health transformation project and updates. So we'll start with that legislative implementation side. I really enjoyed a conversation with our back members this morning, and that we had a real range of experience with the Nevada legislative session. But I think it'd be helpful if we start with just a quick overview of Nevada's approach. I'm sure this is familiar to most MAC members, but always helpful to start from the beginning of how the Nevada process works. But as a reminder, the Nevada legislature meets every other year, and every state does this a little bit differently. We have 120 days on odd years. So February to June of this year was our 83rd legislative session. And through that process, there were, I think, between 800 and 900 bills that were brought forward by legislators or members of the executive branch or other groups. Of those, 176 had some sort of impact on Medicaid. Some of those had a very direct impact on Medicaid. One of them actually was our bill regarding the creation of the MAC and BEC. So that was a very relevant one. Others were actually intended to focus on other areas, but have an impact to Medicaid because of the industry we're in. For example, bills focused on regulating health insurers are maybe focused more on the commercial side of insurance, but Medicaid has health insurance too, right? So we're held to those bills as well. So there were a total of 176 bills that we were tracking throughout that time. And throughout the course of those 120 days, we had, I would say, over 100 folks at Nevada Medicaid working nearly daily on supporting that process. And what that looks like, I wanted to give this group kind of an idea of how does an executive branch agency support the legislative process? And what's important is we are neutral on all bills that are not our budget bill. That is the bill that we bring forward. Otherwise, we serve as technical assistant experts to support the bill sponsors on how to, number one, write a bill that aligns with federal and state requirements for the Medicaid program. So that way they align and we're able to do something that is allowable within federal law and also that would work well for our state. And number two, we work with them to provide an estimate of the fiscal impact of the bill, right? Everything, as our director likes to say, everything good costs money. And so we need to calculate how much money each of these bills would cost to implement. So our teams, over the course of typically a 48-hour period, do a really complex exercise to figure out if this bill were to become law, how much would that cost the state, and how do we help legislators understand those costs so they can make an educated decision on whether to include them in the overall state budget? So we spent a lot of time down in Carson where we have to be at every single bill hearing that has an impact to Medicaid. And so we can provide testimony if called on by the bill sponsor or by the legislature to help clarify, this is what this would really mean. This is how it aligns with federal regulation. This is how it works with providers right now. And we also can speak to our fiscal notes and the cost as well. So we had, I think, around 120 fiscal notes submitted. Those are all available online if you're interested in seeing any of those for particular bills. But in total, as the dust settled after session ended in June, we had a total of 43 bills that were passed that we are now in the process of implementing. And I gave some examples this morning. Some of those are relatively straightforward to implement. For example, establishing the MAC and BEC, right? We're here today. This is technically an implemented bill, right? Yes. Done, check. There's others that are significantly more complex. There were a lot of bills related to prior authorization reform that require system updates on both our side and our health plan partners side that may take up to years to be able to comply with. And so often in the bill language, we would work with a sponsor to set a legislative deadline for the bill that is reasonable for us to be able to implement. We said, hey, this actually is a really big IT project. We're going to need 2 years to do it. So we're beginning that work right now. So what I want to call out is of those 43 bills, there's a lot of changes to our state plan. There's a lot of changes to our policy, right? Our flower is evolving because of those 43 bills. And so we will be bringing those to this group to get your input on. Probably not all 43. There might be some that have more or less relevance. We really want to make sure that you all have input on the way we design it. Because while the bills are usually pretty specific in how they're implemented, there's still a lot of wiggle room on how we actually write our state plan amendment, write our policy, set the reimbursement rates. Those are all things that we have flexibility within the guidelines of the law to be able to design it. And that's where we really need this group's input. So I'd like to pause there. Would welcome any input from the group, whether you've worked with the legislative session this year or in years past. We'd love to hear about your experience with that and any input you all have on bills that have an impact on Medicaid, as well as any areas of focus that you would particularly want to hear about as we go through our implementation process. And I know Minden has shared the link for those online in the chat to our website with the Nevada legislative session detail. We will also share slides from our stakeholder workshop a couple weeks ago that gave some really detailed updates on implementation across all of our program areas. So folks can review that afterwards and send recommendations of particular bills or areas that you guys would like to hear. But I will pause there. All things legislative implementation. What input do you all have, or what areas of focus do you bring to this group?
Azraela here. If upon investigating the 43 bills that are passed, if we have feedback, who do we contact for that?
Mm-hmm. So as part of this group, I think send that feedback to the MAC support team.
Okay.
And they can kind of find the right folks internally to share that with.
Okay.
We will be having a lot of public stakeholder work groups on particular bill implementation. So things like the PA bill, or things like a new service for personal care services for family members delivering that. We will have a dedicated workshop. So if you're interested in that topic, we will have a dedicated hour of time where folks can come and give their input. We may even have multiple of those depending on the topic. But if there's things that come to you in the meantime, we always want to hear them and send those to the team that's working here, and they'll make sure that gets to the right place. So yeah, I appreciate that.
You can send any feedback to community and provider at nvha.nv.gov. I believe Lyndon has also done that in the chat. And then, and PA bill is prior authorization.
Yes, thank you. Acronym alert. Yes, prior authorization bill. Yes, absolutely.
So I will tell you, my experience has been, I have been giving input into some of these bills early on in mid-process through an employee of renown, Chris Bossi, who does connect a lot. I would say 90% of my effort over the last 15, 16 years has been to actually implement them in actual practice, whether it's a BRCA testing throughout the organization, STD testing in the ER. So I've spent most of my career trying to actually make these things work, dealing with IT, which is sometimes difficult, and convincing providers that this is required because it's a law.
Yeah, I appreciate that. As we talk about implementation on our end, implementation is going on across our full state, right? It's not just us that are implementing things. And so I really appreciate that. I would love to hear, if you're willing, like, what are things from this session in particular that are top of mind for you right now?
I have to take some time to go through them. And actually that's what we are doing.
Great.
So I'd rather hold off on that comment for right now.
Oh, of course, no worries. Yeah, I know there is a flurry of things to do. So I'm sure you have quite the list, but I appreciate you sharing that. That's great.
Thank you.
Any others?
Any comments from those online? Committee members?
I've got a question.
Please, yeah.
Grace Larkins, for the record. The in the back meeting, you discussed the OT reimbursement rate increase, which is fabulous. Is that related to that SB 366, which increases the Medicaid reimbursement rates for OTPT?
Yeah, it's actually separate than that. So it's something that it's a process that we started over a year ago, honestly, to increase rates. And that's something that the state, if we have funds available, can request to increase the reimbursement rate for an existing benefit without needing legislative approval. So sometimes the legislature says, hey, please increase the reimbursement for the service. Other times we can make that determination internally if we have funds available. The most direct way is typically through the legislature because they have the funds to give us to do it. But we saw a real need in the occupational therapy services. And so this kind of speaks to how long that process is. Like we just received the approval from the federal government not that long ago, and then we have to go through the whole process of getting our technical system to now reflect that change. It was similar to what was in SB 366, which is a rate increase across those services. But that's actually kind of a separate initiative on our end. So sometimes we all have the same idea, and that's part of the conversations that we have with the bill sponsors to say, hey, we actually are working on this right now. By the time the bill passes, we anticipate our rate will be this. You can make a decision on what your bill reflects, but we can kind of provide that insight. Is that helpful?
Yeah, thank you.
Yeah, absolutely.
We have a raised hand, Casey.
Yeah, Casey.
Hi. My interaction with the legislative process, it was my first time going through the legislative session and followed it really closely, particularly where it impacted provider workforce development and support. So SB 366, we worked closely with the sponsor, Senator Krasner, on to try to help different providers with therapy and mental health through a rate increase. And then we've been extremely grateful to Medicaid for finding funding to be able to do the subspecialty 28 for occupational therapy rate increase. But yes, this was my first time kind of following the process and a bill, bringing that forward, and then providing public testimony and just seeing how the entire process works together. So I'm excited to follow the ones that did pass. and through implementation for Medicaid. So it's very exciting to see.
Yeah. Thank you for sharing that, Casey, and thank you for your hard work. That's what we like to say. Those 120 days are very intense and they're very busy, but the real work really begins once we start implementing it, right? That's when there's a lot of complex things and honestly a lot of decisions to be made on the state side. So we're really glad to have you part of it and look forward to your input as part of that process too.
Thank you.
Wonderful. Any other topics of interest to this group as we plan to bring bills during each of these meetings that we are implementing to get your input on? Are there any particular areas that you all would want to make sure are on that list off the top of your head right now?
Azraella here, family planning services and supplies. I think that's a pretty big topic given that 1 out of 2 births are funded by Medicaid.
Absolutely. Yes, a lot of women's health and maternal health bills this session. And so would be happy, we can give maybe a comprehensive update on that full topic area and what bills are in the process there. Great call. Yeah.
Rahul Mediwala, just a question.
Yeah.
What sort of information will we get before the session so that we can spend some time doing a deep dive on it?
Yeah, great question.
Yes. Yeah, so obviously this is our first meeting. It's meant to kind of just, do some introductions and start discussions, right? And see what other topics we want to bring to future meetings. We will be sending out materials way beforehand. This is just kind of, like I said, introductions and stuff, but we will make sure to get all materials, presentations and things out to members beforehand, for sure. Yes.
Hi, this is Desiree Gomez. I am, of course, interested in pharmacy, but there's certain things that I wanted to see kind of brought before certain antibiotics that I don't want restricted anymore, such as tuberculosis medications that I do want to see if that can be revisited.
Yeah, thank you for sharing. There's a lot of pharmacy work that happened during session. We have a really excellent pharmacy director, Dr. Keiko Duncan, and she and I spent a lot of time down in that building in Carson. And I think it'd be great. I appreciate you raising on the antibiotic side as well. So I think it may be helpful. We can add that to the list of agenda topics that Dr. Duncan and team could come and give an update on our pharmacy program more generally, as well as opportunities for members to join some of our drug utilization review board meetings as well, where some of those decisions are made on restrictions and coverage of certain medication as well. So thank you for raising that. Would love to cover that with this group, and then also happy to connect you with them in further forums as well. All right. Anything else on the legislative side? All right. Okay. So we're going to move to our next topic here on statewide managed care. So we talked about big date that we're all working towards is January 1st of 2026, which is hard to believe, only less than 4 months away. So we anticipate about 70,000 Nevadans that live in rural counties will transition from fee-for-service to managed care. There's 5 total managed care organizations that were awarded contracts across the whole state, 4 of which will be returning to the state, meaning they already had contracts, and 1 of which is new to our market, which is CareSource. They are a nonprofit health plan that's new to our state. So in our rural areas, the 2 plans will be CareSource and Silver Summit, and they're working really hard to contract with providers in the rural areas and to really start communicating directly with members to let them know about this transition. And so there's 2 things that I really want to get this team's input on. One is on the provider side, for those that are transitioning to managed care or who there's a new plan coming to your area, what information would be helpful? How can we make that process as smooth as possible? We've been working very closely with our managed care organizations, and I'm really appreciative of their thoughtful approach to this, doing dry runs of claims testing and all the nitty-gritty details to make sure that's possible. But we recognize this is a significant change to operations. And so how can we best support you all through that transition? And the second question is, how should we think about communicating with our recipients who are impacted in some way by this? For the folks in the rural areas, that means a new name on the insurance card, right? This is a big change. And so helping them really understand what the benefits are of this program and what that will look and feel like. For recipients in Washington and Clark, their plan may change. And so that reassignment will happen on January 1st. They have an opportunity to change plans for the next 3 months. And there's a lot of kind of continuity of care requirements to make sure their previous plans coverage is met during that transition period. But we really want to make sure we're anticipating and proactively working with folks to navigate this change. We had a great discussion with our back folks this morning on what some of that recipient communication can look like. So I welcome if any back members want to share a summary of that or your approach for that. We'd love for the full group to hear, but it's really crucial for us that we can support people through this. We know it can be disruptive to change plans, and that disruption is somewhat inevitable, but we can make it feel more smooth and make sure people feel equipped to make the right decision for them. So I'll start with our back members if anyone would like to share a little bit more from this morning's discussion or new thoughts you all have had, and then we can open up to our broader group and welcome answers to either the provider or the recipient side.
Azraella here. I'm a Medicaid recipient and also was at this morning's meeting. Basically, a summary of what was discussed is that Medicaid recipients would like to hear via the app, either via email or mailed. And I also offered the input of welfare office informing recipients of the new changes as well.
Well, we have Robert Thompson, who's our administrator of the Division of Social Services, who leads our welfare team, on the line. Do you want to share a little bit more about that context? I thought that was a really good suggestion about people's familiarity with the welfare offices and that involvement. Do you want to share that?
Right. So people who are in transition of housing and also homeless are more likely to go to the welfare office because they're receiving a lot of benefits in one location, more so than a Medicaid office. And the welfare office would be a good resource because every 6 months we recipients have to recertify for the application, and that way Medicaid can get the most updated information, whether address, phone number, and what other contact information they might need.
Thank you. I appreciate that.
Yeah.
Grace Larkins. One thing that I recall we spoke about as well is there a way to look at the data in past efforts in getting messaging out on something and in outreach that had success, that were more successful than others, and also interested to find out if there is some data tracked on who has the bounce backs that are coming from snail mail and email and phone, so that those are not redundant or just unnecessary work.
Yeah, absolutely. If any of our health plan representatives on the call want to speak to that, we welcome you to, but that's something that we also talked about we'll bring to our upcoming meetings as well. There's a lot of really good analytics around these marketing efforts, and I think that'd be a great thing to lift up the hood on and share a little bit more about at our upcoming meeting. So thank you for raising that. All right. Any other broader group input on how can we really proactively think about smoothing this transition for both our providers and recipients? Any thoughts there?
I'm more familiar with commercial plans
Yeah.
and change.
Yeah.
So is there a transition period where an existing provider relationship is honored for a period of time?
Yes, great question. And there is. We call that our kind of care transition period. And that ranges between 3 and 6 months, depending on the plan and the recipient. But we have really clear guidelines in our contracts with each health plan about what that looks like, because we recognize that's a really crucial transition and we can't have folks missing prescriptions or not being able to attend scheduled appointments during that period. So yes, I imagine it will look fairly similar to what a commercial transition plan would look like. We also have those same requirements for folks coming onto Medicaid from non-Medicaid plans. So if for folks that were enrolled in a Medicare Advantage plan or a commercial plan, it's very similar as well. So yeah, thank you for raising that. As a provider, how has that process been navigating? Do you feel like you have the information from those previous plans that you need to be able to make that determination?
I mean, I think it's always an emotional time
Yeah.
for providers. And I think what is most challenging is when you have to change providers. And I would say changing either a primary care provider or a specialist in that condition is been the most challenging piece of it all.
Yep.
I think there is information, but then there's emotion involved in it. And then there is trust and care. And so that's always been the challenge as a provider.
Yeah. Are there things, I know some of those emotions are just part of any transition, right? Change is hard for all of us, but from your perspective, are there things that from the Medicaid side we can do or from the health plan side we can do to really support that transition process?
I think getting the information out early as we are discussing is going to be vitally important. I think there is also a piece of this of understanding the network and the availability.
Yeah.
And I think that from a provider standpoint, I'll just give an example.
Please.
A specialist might be listed as a specialist, but might specialize in something further. So if someone needs a particularly subspecialty type care, and if there's one person in the community that really involves that care, it doesn't matter if you have 2 or 3 specialist options. It's the person involved. So I think there's a little bit more detail at the very high level, but I think what's incredibly important is ensuring that there is an adequate network to transfer patients to, and that there is capacity within that network. So it doesn't matter if there is a network, if you can't get in for 6 months and the transition period is 3 months to 6 months, it will be challenging.
Yeah, I appreciate that. And there are a lot of changes at the federal level. So that flower pot regulation change, there's a big rule that came out that kind of redefined what network adequacy standards need to look like to really reflect that. And so that's incorporated in this new contract in hopes of really addressing some of those concerns. But we talked a lot about that this morning as well. We all know provider workforce in the state is a significant challenge. And so how do we balance that appropriately and ensure that it's not just, a check that there's a specialist, it's really the right specialist for that patient and their condition. And that can be a real challenge. So yeah, thank you for sharing that. I appreciate that. Any others online? Any other committee members that want to share on the statewide transition, initial input or recommendations or questions?
I have a question. Do we have any way to text recipients that their plan will be changing or anything? Because I have a lot of people come into the pharmacy and they have no idea that this is going on. They're surprised that something has changed. Is there any way, because you said the app, but is there a way to text, because we text them through their phone and then they can receive messages. So do you have a way to text saying something like your plan will be changing, go on the app, something like that, because that might give them a heads up?
Yeah, no, that's a great suggestion. Thank you for that. And folks finding out of the pharmacy is probably one of the worst times to ever find that out. So I hear you. We want to really avoid that whenever possible. There are mechanisms for both Medicaid and also for our plans to be able to text recipients. So the details of what's included as part of our notification plan, I think we should bring that to our next meeting to get your all's input on. I think the tension and the balance we're trying to strike is, we all know this, the number of spam texts we get is skyrocketing these days, right? And so how do we text at the right time and in a manner that folks really trust, while also recognizing most people are more likely to respond and read a text than answer a phone call. So it's probably one of the best ways to get a hold of folks, but we need to strike the right balance of how often we do that. So we'll ask the team that's working on that to pull together a summary of what the plans are for that outreach, and we'll bring that to the group in November. I think that'd be a great topic for us. So thank you for that suggestion.
And hello, JC, I do see your hand up. However, this currently is a discussion for committee members. If you wouldn't mind holding your question until the public comment period later on in the agenda, we would love to hear your question then. Thank you so much.
Thanks, JC. Good to see you. All right. Any other? Yes, please go ahead.
Hi, Grace Larkins for the record. I'm just curious what it would look like for, say, a family in the rurals, if I were to place myself in, say, one of the frontier counties. So my impression that to this point, recipients are able to choose which MCO company or provider they would like to go, or which MCO they'd like to go with. So in the rurals and frontier communities, when this switch happens, are they automatically, is that going to be automatic? Are they automatically going to be all with one of those MCOs, and are those by geographically? Is it already assigned? Would they just all of a sudden get a letter from, say, Melina or whatever it may be, that they are with them and they would not have known in advance? Or how does that going to look?
Yeah, no, I appreciate that. And I think that's the right angle to be asking the question, right? Like, what does this look and feel like from their perspective? So the way that assignment works, it's a really complicated algorithm, but at the beginning of every managed care contract, there are very set requirements on how patients are assigned to managed care organizations across the whole state. So for someone that's living in Ely, for example, they would be auto-assigned to either Silver Summit or to CareSource. They will be notified of that assignment from the plan, and they'll say, hey, you know, your care is transitioned to our plan, and there's going to be a lot of ways that notification goes out, and that's what we can work with our folks to bring kind of that full detail of whether that will be mail first and then text and call, or you know what's the sequencing of that. But at that point, they have 90 days to make a change. So say that family was assigned to CareSource, but for some reason they feel that the additional benefits offered by Silver Summit are more aligned with their family's needs, they could make that change at the time, and the notification that they get from CareSource would include that information as well. So during the contract period, folks can always, when they're enrolling in Medicaid, they can make a choice. And if they don't make a choice, then they're auto-assigned. It's just the wonkiness of the beginning of a contract period. Everyone is auto-assigned to start, and then they can make their choice from there. Does that help answer your question?
Gotcha.
Yeah.
And that's where we're talking, ideally, they're going to get that first heads up by some of these means that we've been talking about.
Exactly.
Before it's just, they get it from Silver Summit or whatever. So one other question regarding the rules, when having a child with special health care needs, so we have a lot of different specialists and therapists, and when there is a change in insurance and all of it can be very destabilizing and scary and sometimes dangerous when our regular providers are no longer covered and we're having to find new people. So in the rules, when there's so few providers already, say you're in a community that only has, 1, 2, 3 providers, is it potentially could, those that are assigned right there in that community not be in that, be contracted with their kind of only options? Are there?
Yeah, no, it's the right question. So the network adequacy standards that you were mentioning earlier are really crucial for our rural areas, right? So we have specific requirements around what that looks like, including all critical access hospitals and ensuring that that rural network reflects as many providers as possible in our rural communities. So the intent is that folks would only be assigned to a plan that has providers and network in their area. But in the case that that does not happen, or there's some change, that would be a great example of when a change would be the potential. But I will say CareSource and Silver Summit both have been working really hard to contract that network and ensure that they have all the folks that they possibly can in network on January 1st. So I feel confident that folks that are assigned to either plan will have access to the services that they need, but it will be an ongoing process to make sure people have that. Because I recognize this is where it's really crucial. It's not just a change on paper, right? It is what it feels like to have a provider potentially not be part of a network, and that can be really, to your point, destabilizing. So I appreciate that. Absolutely. Yeah.
So Bill Sons for the record. So my question is, just because, I used to live in Fallon years ago, that being a rural community and everything, given these changes are set to take effect on January 1st, how far in advance are these patients going to be given notice so that they can start getting ready for it before they just get the text saying, oh, by the way, you're being moved over to this kind of plan?
Yeah.
I mean, is it just a day, or is it going to be a week, a month, like December, November, or how is that going to work for them?
Yeah, that's all right. I really appreciate that question. So we've actually been having more general notifications about the transition to managed care going out to our rural members for the past year. So we've been really trying to share, well, we don't have details on even who was going to be the provider at the time. We said, hey, this transition is happening. So our team, our stakeholder engagement team, has been going to a lot of health fairs throughout the state to really ensure that folks, health fairs and school events and tribal events, and sharing the news that, hey, changes are coming January 1st, stay tuned, right? Things will look and feel different then. Once the selections of our plans in those rural areas was announced, then Silver Summit and CareSource started to do the same thing. So they have folks that live and work in those communities that have been driving across the whole state to conduct events and really try to get the word out that this is coming, which is great. I know we're all spending a day together in Fallon next week at a big back to school health fair where we'll be talking about the transition as well. So there are a lot of more general notifications that this is coming ahead of time.
Okay.
In terms of your specific question about when do you know about your plan, that will be closer to the period. It's between December and January 1st that folks will be notified of where their plan will be. So it's a relatively tight turnaround, but that's because of the implementation part. We want to make sure that we know exactly how many members are in our network at the time that assignment is made. And so that will be a really rapid fire conversation, or not conversation, rapid fire notification process to make sure people have all the information they need going into January 1st.
Okay.
Is that helpful?
Yeah.
Yeah, thank you.
Azraella here. In addition to what they were commenting, I'm a recipient of fee-for-service, and our access to care is already very limited. So having access to a managed care program such as Silver Summit or CareSource is going to be an incredibly valuable resource for fee-for-services Medicaid recipients.
I appreciate you sharing that, and we're looking forward to your feedback. You will get those notifications right in the mail and over text. So
hopefully I'm not one of the few that doesn't to pass that.
No, we will. Yeah, I'm really looking forward to your feedback through that. And I know we have some Silver Summit team members on the line. CareSource is not on the call today, but they will be joining in future meetings as well. But Silver Summit team, is there anything for our Silver Summit representative that you want to share on that transition piece that I may have missed as well?
Hi, thanks, Ann. This is Nikki. Yeah, so we are, as you said, and I appreciate you, all the kudos, because it is a ton of work to get ready to go out, and we take it really, really seriously. So my team is on the ground throughout rural Nevada right now, literally as we speak, educating all of the CBOs. My colleague, Sarah Fox, who's over VP of Network, her team is on the ground educating all the providers. We're building toolkits, which we will be distributing throughout all of the communities, posters, flyers, brochures, with the specific intent of educating the community and the recipients on the change that's coming. And our main message is, don't worry, just keep going to the doctor. Because of that continuity of care policy that's in place, the members, the recipients, they just need to keep going to the doctor. And the other thing that we spend a lot of time on is educating the providers that they don't have to bear the burden of understanding the differences between CareSource and Silver Summit. So that's why we're providing them the toolkit of information so that they can say to the patient when they come, and the patients will, some of them will be confused, right? And they'll say, like, I got this card, I don't even know what this is. So then the providers and the receptionists are equipped with the answer. It's okay, you're going to keep your appointment today, and here's Silver Summit's member services number, so you can call them to learn more. So I'm happy to answer any questions, but that's just in the general gist of what we're doing.
Wonderful. Thank you, Nikki. I appreciate it, and all your team is doing. I know the rural road tours are occurring for all of us right now. I'm going out with our team for a week very soon to meet with providers and really try to hear from them how we can best support. And then we're going to do the same thing this spring and say, hey, how's it going, right? We're a couple months in. How can we best support you? So really appreciate all your team is doing. And quick acronym check, CBO. Do you want to explain to folks what CBO means?
Thank you. Yes. Community-based organizations. So all the food banks and the housing providers, housing support providers, everyone who provides all the services that our members need outside of the traditional medical office.
Awesome. Thanks, Nikki. I appreciate it. And Dr. Green, I'm seeing your comment. Thank you so much for being here. Would love for you to share, as part of our public comment period, a little bit more about CareSource's similar work. I know there's a lot of excellent work happening there. We just want to make sure that we're saving this. I'm following the rules of open meeting law, that we're keeping our committee members commenting during this period, and then we'd love to have you share during the public comment period. So thank you for being on and for all your team is doing as well.
Absolutely.
Great. All right. Any final closing thoughts on statewide transition? And please know that we will be talking about this a lot. This is one of our top areas of focus right now. So if things come to you that you have input on, please send those our team's way, and we'd love to hear them. All right, great. My last item will be a bit shorter, more so focused on an update and an ask, a teaser for future conversations related to children's behavioral health transformation. So for those who aren't familiar about this work overall, this stems from what we all know is a really significant need in our state for access to children's behavioral health services. We're currently ranked last in the nation for outcomes for kids with behavioral health needs, and none of us want to be last in any of this. I think since moving, I've moved to Nevada just over a year ago, and I don't know that in my personal life and in my professional life, I've met so many folks that have shared really personal experiences with me of challenges they face trying to navigate our system. And I really care deeply about our work to try to improve that. So I'm really grateful we have the chance to do it. This work within the Medicaid realm more formally stems from a finding from the Department of Justice when they reviewed the state of Nevada's activities regarding children's behavioral health and found the state to be out of compliance with the Americans with Disabilities Act. And the basis of that finding was because kids with behavioral health disabilities were too often being cared for in residential or institutional settings and not at home and in their communities. And that's a protection afforded by the Americans with Disabilities Act for anyone across the US. And so the settlement agreement that we reached with the Department of Justice in January of this year really reflects our state's commitment to developing the full continuum of behavioral health services, to say we shouldn't say the only option to get the care that you need is in a residential treatment facility. It should be therapy provided at home with the family unit or in school or as part of a foster therapy program, right? We need to develop those home and community-based benefits in a way that often these services are already being provided. I'm really excited that Casey's here representing children's therapy. There's a lot of great work happening across our full state, but Medicaid hasn't always been able to pay for it, right? Our flower hasn't always reflected an ability to support that. So that's really what we're focused on. We have done a lot of work over the past year, even more before that settlement agreement was reached, to develop secure legislative funding for this. We have a funding mechanism through our hospital tax that helps pay for this, which is really unique. Most states have to figure out how to pay for it by rearranging the money that we already have. We actually have new money to support this, which is huge. And so we're really in the thick of securing federal approval for those new benefits and helping support the provider workforce development. We know there's significant need to have more providers in our state, so partnering with our sister agencies to do that. And then lastly, we're developing what is called a specialty managed care plan. So this is going to be a net new plan in our network that is specific to kids with behavioral health needs. It's going to have really enhanced care coordination that's really specific to this experience and is intended to help kids and families navigate all the services they're involved in. We know these kids often are involved with a lot of school systems and foster care systems or juvenile justice systems, our disability services division, right? There's just a host of really complicated paths that our families need to navigate, and we can do better by supporting them through that. And so our specialty plan is really intended to provide that care coordination and also to really ensure that there's a robust array of benefits available in that plan. So I want to acknowledge we have a working group that's made up of youth and family members and providers that meet virtually every month. Any member of the public is welcome to join. We'd love to have you there. Our next meeting is tomorrow, Thursday. We're at 4:30 tomorrow. We'll be talking about care coordination and what does that look and feel like for our families and how can we best design that. We're going to do a summit, like a deep dive with our family member representatives as well next month on this topic. And all of that is to inform the way that we design this plan. So my ask is for this group, if you're interested in learning more and are not already engaged on that, I do see many familiar faces and I'm super appreciative of all your input throughout the course of this project. We'd love to have you join us. This is a long game project. We are in this work for a long time, and I really would love as many folks to chime in on how best we can design this plan and these benefits to serve our community and to continue to improve them over the years. So if you'd like to join the working groups, you're always welcome to do so. We'll drop the link to our website with all that information. And if you want to catch up on past working groups, you're welcome to do that there. And we'll acknowledge that we'll continue to bring, this will probably be a standing item that I'll give an update on every single meeting. So you all know where we are in that process, because I know that's a shared focus and priority area for everyone. And I want to make sure this group is informed and has a chance to provide input there. So any questions or comments on the children's behavioral health side?
One quick question on
Please.
that one.
No need for it to be quick.
The recent understanding that the hospital taxes and provider taxes rate is going to be decreased.
Yeah.
Right, I guess year by year, is it 0.5% per year? And and that's the funding is the hospital tax funding for this. How does that affect the plan?
Yeah, great question. So what she's mentioning is the federal legislation that just passed in July has an impact on that hospital tax program I mentioned, which is a source of funding for our hospitals across the state, as well as a portion of that gets saved for children's behavioral health. So in our stakeholder workshop we did a couple weeks ago, we'll share that content for folks that may have missed it. We did a deeper dive on the numbers behind that and what that looks like, but at a high level, the impact will be felt of that decrease starting in 2028, 2029. So not this budget cycle for the state, but the next one. We do see an impact to the funds for children's behavioral health. It's not going away. It's just less that goes into that pot every year. And so what we're looking at internally right now is how can we supplement those funds with state general funds in our budget request for the next legislative cycle to make sure we're still able to continue these efforts. The funding mechanisms just may look a little bit different. So we're in the early stages of those conversations internally. Stacy shared more about that at our stakeholder workshop, and we'll continue to get feedback from our working group and from this group as we go through that process in the years ahead to make sure that we can really, and this remains a top priority for our work. We may just have to get a little more creative with how it's funded. Is that helpful?
Thank you.
Ella here. I have a couple of comments and questions. In the first meeting, we spoke about adoption. I believe someone's on the line, a member, about adoptive services. And I wonder how that relationship is with Medicaid, if there's improved access for mothers to give up their infants for adoption. When I was having my second child, we were in the midst of COVID, so we didn't actually have services or access to services to consider adoption. And I'm wondering if that's like similar to today's effort because of maybe it's overfilled or there's just not enough resources for it. But I believe that behavioral health starts really, really young. And if we address the issue onset, then it will reduce later costs. So if that person from welfare wants to talk about that.
Yeah. So I know Administrator McDade Williams is on the call, so I'd love to turn to her to answer the first part of your question on what that adoption resources looks like right now post-COVID. I'll just briefly say we, as part of the Children's Behavioral Health Project, we believe that that in early intervention and prevention phase of the continuum is crucial. And I've been learning a lot about infant mental health, which is a growing field, and it's really crucial to this work. We recognize there's kids right now that need support in more of a crisis intervention service, but we can't wait till kids get to that point to provide them services. And so the benefit of the settlement and our focus here is that we're trying to go as upstream as possible, not waiting till a kid has a diagnosis or a determination to get them support and to get our families support. So we're really trying to design that plan and our benefits in a way that really decreases barriers to access so kids can get that as early as possible. But Marla, do you want to speak to the piece on the adoptive services component?
Thank you, Marla McDade Williams. I guess what I would say broadly is that, as you may know, Nevada has a losing the word, but there are 3 child welfare jurisdictions in the state. Clark County manages its own child welfare jurisdiction, Washoe County, and then the Division of Child and Family Services manages rural child welfare in the 15 rural counties. As it relates to adoption assistance, each jurisdiction is responsible for ensuring that they support families through adoption services that are needed for them. Now that, there's once a child has been adopted out of the foster care system, they are eligible for certain subsidies, but we acknowledge that putting together the services that any family needs are they're case by case for each family, and they really have to be worked through the caseworkers managing in the child welfare systems. So that's broadly how that system works. And I think, you know, we did have legislation in this last legislative session that would funnel more money towards the jurisdictions for adoption assistance. We're in the process of implementing that through each child welfare jurisdiction, but I'm happy to answer any more specific questions if someone wants to send me an email.
Thank you, Marla.
And we'll make sure you get Marla's email if you have thoughts.
Appreciate it.
Yeah, thank you so much, Marla. I appreciate that. All right, any other questions? Feedback on the children's behavioral health transformation?
Just want to give an opportunity for other members online that would like to speak on this topic.
All right. Well, thank you all for your input. I'm really excited to continue to give updates on this. This project is near and dear to all of our hearts, I know, and is a huge effort. There's an army of folks working on this every day at Medicaid and also within our sister agencies and our county partners. So really excited to keep sharing updates on that throughout the course of this project. So with that, I want to thank you guys. I know that was a lot of content, a lot of me talking. Appreciate your patience. And I will turn it back over to Nahibi.
Okay, so we are going to go ahead, and this is Nahibi for the record. We are going to go ahead and move into our next agenda topic, which is the discussion of the MAC bylaws. And so our goal today is to review the MAC bylaws to ensure they align with our current needs and objectives. And so we could pull those up to share on the screen. We'd like to go over the bylaws and get any feedback. So we did do the back bylaws earlier in today's meeting. And so we'll kind of do a similar format of reading the bylaws together and providing any feedback, if any. And so for the first section of the MAC bylaws, we have our definitions. So administrator shall mean the state's administrator of the Medicaid division. MAC shall mean the Beneficiary Advisory Council. Director shall mean the state's director of the Nevada Health Authority. Exhibit shall mean a document to be presented to the MAC whereby the MAC is apprised of proposed changes in policy, regulation of the state plan. An exhibit may require an action/vote by the MAC. MAC shall mean the Medicaid Advisory Committee. MAC coordinator shall mean the NVHA staff person assigned to coordinate the MAC, act as secretary, and provide staff assistance to the MAC and its subcommittees. Medicaid shall mean the Medicaid program that is administered by the Nevada Health Authority. Quorum shall have the meaning stated in the Nevada Revised Statutes 241.0156 as a simple majority of the voting membership of the public body or another proportion established by law. State plan shall mean the federally required plan adopted by the Nevada Health Authority and the Medicaid Division to administer the Medicaid program. The state plans under Title 19 and 21 of the Social Security Act constitute the contract under which the Medicaid program operates and federal financial participation is secured. Any questions on definitions? I feel like that's pretty. Yeah, so, okay, perfect. We will go ahead and move on to the next section, creation. So the MAC is created within the Medicaid division of the Nevada Health Authority by federal regulations, specifically 42 CFR 431.12, 1902A 22 of the Social Security Act, effective July 9, 2025, and by Assembly Bill 556 of the 2025 session of the Nevada Legislature, which is not yet codified to the Nevada Revised Statute. Number of members, the MAC shall be comprised of the number of members required by AB 556. In addition, the MAC will have the power granted herein to form subcommittees, each with 3 appointed members, of which 1 will be a MAC member who also serves on the BAC. The chair of the MAC shall appoint members to subcommittees as necessary. The Medicaid Medical Director, we're on to the appointment section. The Medicaid Medical Director, the Administrator of the Division of Social Services, Administrator of the Aging and Disability Services Division, and Administrator of the Division of Child and Family Services of the Nevada Department of Human Services, or his or her designee, shall each serve as ex officio, non-voting members for the MAC. The director shall appoint the remaining members of the MAC. The members of the MAC, including members of any other subcommittees formed pursuant hereto, shall serve as strictly at the pleasure of the director. I'll stop there. Are there any questions on any of these sections or needed for clarification? Okay, seeing none in the room and online, we'll move on to the next section, conflict of interest. Conflicts of interest must be declared by members prior to discussion of any matter that would provide direct financial benefit for that member or otherwise have the appearance of a conflict of interest. When funding recommendations or other decisions are made regarding an organization with which the member has an affiliation, the member shall state his or her intention to abstain from making specific motions or casting a vote before participating in related discussion. The next section goes over our membership, officers, and assistants. So here are the qualifications for membership in the MAC and subcommittees. The appointed members of the MAC, with the exception of the ex officio members, shall consist of the following individuals. A person who holds a license to practice medicine in the state and is certified by the Board of Medical Examiners in a medical specialty. A person who holds a license to practice dentistry in this state. A person who holds a certificate of registration as a pharmacist in the state. A member of a profession in the field of healthcare who is familiar with the needs of persons of low income, the resources required for their care, and the availability of those resources. An administrator of a hospital or a clinic for healthcare. An administrator of a facility for intermediate care or a facility for skilled nursing. A member of the executive leadership of the Medicaid division. A member of an organized group that provides assistance, representation, or other support to recipients of Medicaid. Recipients of Medicaid who concurrently serve on the state's Beneficiary Advisory Council, the BAC, pursuant to AB 556, 2025 legislative session, and in an amount equal to a minimum of 25% of the total voting membership of the MAC. A representative of each of the division's contracted managed care plans. And that might be it for that section. Any questions there? Perfect. The next section goes over terms. The director shall appoint each member of the MAC and appropriate subcommittee to a term of 2 years. Terms begin as of the date of the appointment. MAC members may serve more than one term. However, those terms may not be served consecutively. The division will seek interest from enrolled providers and other groups as necessary to fill vacancies and will post the recruitment process for the MAC publicly. Nominations for new potential members of the MAC will be submitted to the director by the MAC coordinator within the Medicaid division as vacancies occur on the MAC. And that recruitment policy is already live on our website as well and available. Legacy MAC members will have a 1-year term that begins at the adoption of these bylaws to facilitate the transition from the former Medicaid Advisory Committee to the Medicaid Advisory Committee. Each member is expected to participate in a majority of meetings and activities held in a single calendar year. The director may request that a member resign due to absences. Any questions or feedback on this section? Seeing none, move on to section 3, officers. Before the first meeting of the calendar year, the director shall appoint a chair and a vice chair. The Medicaid Division Administrator or his or her designee shall serve as the MAC coordinator and the secretary for the MAC. The chair and vice chair will serve a term of 2 years. The director shall appoint a replacement in the event a replacement is needed for the chair and vice chair positions. The chair shall preside at all meetings and generally supervise the affairs of the MAC or designate a representative to do so. The vice chair shall assist and assume the duties of the chair in case of the chair's absence. Section 4, staff assistance. The Medicaid division must provide the MAC staff with assistance and independent technical assistance as needed to enable it to accomplish its functions and duties through the MAC coordinator. Any questions here?
Azraella here. Can Medicaid recipients hold office or like a chair or vice chair position?
Yes. Any other questions? All right, to the meetings section, frequency and location. The members of the MAC shall meet at least once per quarter as required by 42 CFR 431.12. In section 2, the agenda. The MAC coordinator shall be responsible for drafting an agenda for each MAC meeting, and such agenda shall be distributed to each member no later than 30 business days prior to each meeting. The MAC and any applicable subcommittees will conduct their meetings pursuant to the open meeting law set forth in NRS Chapter 214. Each appointed member of the MAC is encouraged to provide agenda items for consideration on an annual basis, January through December, to the Secretary for the MAC, which is provided through the Medicaid Division. The MAC Chair will assist the MAC Coordinator in the development of the agenda. Any agenda items can be sent to community and provider at nvha.nv.gov. Section 3, minutes. Pursuant to NRS 241.035, the MAC and applicable subcommittees shall keep, retain, and make available for public inspection written minutes of each meeting. The MAC shall record each meeting. Minutes or recordings must be made available for inspection by the public within 30 working days after each meeting. Minutes are deemed to have permanent value and must be retained by the Medicaid Division for at least 5 years. Thereafter, minutes may be transferred for archival preservation in accordance with NRS 239.080 through 239.125 inclusive. For section 4, voting, each of the members constituting a quorum of the MAC shall vote to approve or disapprove each action item on the agenda. And minutes and recordings will be posted on our MAC website as well, which will provide that link in the follow-up email as well. Article 5, functions and duties. Section 1, functions. The purpose of the MAC is to advise the Medicaid Division on matters of concern related to policy development and the effective administration of the Medicaid program. To advise the administrator regarding the provision of services and the ability to access these services for the health and medical care of welfare recipients. To increase the participation of welfare recipients in the development of policy and administration of programs by the Medicaid Division. To review managed care health plan marketing materials and serve in a consultative capacity to Medicaid pursuant to Section 4707A of the Balanced Budget Act of 1997. To advise and consult on fee-for-service rates where payments are made to direct care workers providing self-directed and agency-directed personal care, home health aid, and homemaker services as described in 440.180B2 through 4 and 6 biannually with the first recommendation to the Medicaid Division due by July 9, 2026. The MAC must submit an annual report describing its activities, topics discussed, and recommendations to the Medicaid Division. The report will be reviewed by the administrator who will respond to the recommended actions and provide the MAC with final review of the report. The administrator will also ensure a portion of the annual report includes a section on the activities, discussed topics, and recommendations of the MAC, along with responses to those recommendations. This report is due on or before July 1st of each year to the administrator of the Medicaid Division and will be posted publicly with the first report due on or before July 1st, 2026. Any questions on this portion? I know that was kind of a lot.
Azraella here. On section E, it says self-directed and agency-directed personal care, home health aid, and homemaker services. I guess I'm not familiar with the law that it's pertaining to. What does the jargon mean? That seems upsetting right there.
Do you need me to step in, Nahivi, or do you have it?
No, Monica, if you don't mind stepping in, that would be great.
So we are talking about item E here to advise and consult on fee-for-service rates. Is that, I just want to make sure I heard that correctly. Okay,
yes, for direct care workers.
Okay, so as part of a final rule that came out from the Centers for Medicaid Services, CMS, last year, I believe July 9th, 2024. Melody Hall Ramirez may be on the line, and I might have her correct me if I'm saying anything out of turn. But as part of that final rule, there was a requirement to have a kind of a committee come together every 2 years to review the rates paid to direct care workers and make suggestions and look at that. Those rules were folded into the Medicaid Advisory Committee as allowable by that CMS rule. And I can put that rule number in the chat. I'm sorry, I think it's 2942, but I don't have it off the top of my head. But I'm happy to put that information in there. And that is where that comes from. It needs to be looked at every 2 years. And so instead of trying to keep a committee that only meets every 2 years, we thought that this would be a good place for us to have those discussions.
Here. Yes, at these committee meetings, yeah. And we can send you more information after the meeting on that.
Sounds good. Thanks.
Yes, of course. Any other questions or comments? I want to check in with those online. Right, seeing none, do you mind scrolling down just a little bit? Have we gone into exhibits? No, okay. Section 2, exhibits. Members of the MAC shall review changes in policy, regulations, and the administration of Medicaid's healthcare programs, and shall advise the Medicaid division thereon by providing recommendations regarding such changes. Proposals may be presented as exhibits having information, including but not limited to details regarding the present policy, future policy goals, and possible costs or savings related to any potential policy changes. Exhibits shall be provided to each member via electronic mail 10 business days prior to each MAC meeting. Section 3, briefings. Medicaid staff will be available to conduct oral presentations on pending issues of significance to Medicaid. The MAC may request written briefings. Exhibits shall be provided to MAC members 10 business days in advance of each scheduled meeting. So this kind of pertains to having, those documents earlier to, review before the meetings.
Got it. Thanks.
Any questions on this portion? Perfect. Article 6, compensation. Section 1, members of the MAC in any subcommittee shall serve without compensation with the exception of MAC members who also serve on the BAC. Each member of the MAC who is a recipient of Medicaid is entitled to receive compensation while engaged in the business of the advisory committee in the form of transportation vouchers, childcare reimbursement, or other reimbursement in addition to per diem allowance and travel expenses provided for state offers and employees generally. Per diem and other expenses, while engaged in the business of the MAC or any applicable subcommittee, each member is entitled to receive the per diem allowance and travel expenses generally provided for state officers and employees. Any questions on this article section? Okay. Article 7, adoption and amendments to the bylaws. Proposed amendments to these bylaws must be submitted in writing to the MAC members and the director 45 days in advance of a scheduled meeting to be acted upon. A quorum of the members present shall be required to adopt a proposed amendment, and such amendments must be approved by the director to become effective.
Question.
Yes.
Is the director Stacy?
Correct.
Okay.
Yeah. Director of the Nevada Health Authority. Yes. Any other questions, clarification on the bylaws? Checking in with those online. Perfect. I will go ahead and move to the next agenda item for possible action vote on the MAC bylaws. If there are no suggested updates to the bylaws, we can accept a motion to the bylaws to adopt the bylaws as written. Would anyone like to make a motion?
I'll make a motion.
Bill Sims will be making a motion. Do I have a second?
Second.
And Jensen with the second. We will go ahead and call roll to hear all of those in favor, say aye. For all of those not in favor or opposed, say nay.
Bill,
Aye.
Azriela,
Aye.
Grace,
Hi.
Kilani,
Aye.
Don,
Aye.
Dr. Mediwala,
Aye.
Dr. Gomez,
Aye.
Casey,
Aye.
Shauna,
Aye.
Brooke,
Oh, yes. Brooke Greenlee.
Kim,
Aye.
Nicole,
Aye.
and Ann.
Aye. And the motion carries. The bylaws are adopted as written. A final copy of the bylaws will be posted to the Medicaid Advisory Committee webpage and will be provided following this meeting. Perfect. It's great. I will, I still have the rest of the agenda. Okay. So we will move on to our next agenda item, which is the next meeting, which will be held on November 10th, 2025 at 1 p.m. We are planning to have this meeting in the Southern Nevada region. We are still looking on securing a location, so we will notify everyone once we have that location. If you are hoping to try to travel for this, please let us know as soon as possible. And like this meeting will also be hybrid, so there will be a virtual option available as well. Again, if there are any agenda topics you would like to see on the next Medicaid Advisory Committee meeting, please let us know, and we can work on getting those items ready for that meeting. Next, we will go ahead and open it for public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and to spell their last name and provide mschiffer@nvha.nv.gov with written comments. Comments must be provided up to and including the day of the meeting by 5 p.m. for inclusion on the record. If you would like to provide public comment, please raise your hand in the Teams app or type public comment in the chat along with your name so you can be called on to begin. If you are joining the meeting by phone, you can raise your hand by pressing *5 on your keypad. When we call on you, we will identify you by the last 4 digits of your phone number. When you are called on, please state your first and last name at the beginning. For recording purposes, you will have 3 minutes to speak. And I'll go ahead and just read some of the comments before we look for any raised hands. From Deanna for public comment. Her mic is not working. Is it possible for providers to receive a list of patients who will be transitioning from fee-for-service to an MCO or being reassigned to a different MCO on January 1st, 2026? Having this list in advance would help us identify which patients will be affected and prepare accordingly. We received similar lists the last time MCOs were switched a while ago, and it was extremely helpful in ensuring a smooth transition for patients. Thank you, Deanna, for your comment. We will look into this and follow up with you. If you could please put your email in the chat, that would be great. Monica did put in the, thank you, Deanna. Monica did put a comment in there. Public comment would be a good place to make any agenda item suggestions as well for next meeting. And then I know there were a couple of those that wanted to provide comment during the meeting, but were unable to because we were not in the public comment period. However, I just wanted to see if they wanted to speak on those items, JC or Tracy Green.
Hi, Dr. Green and JC Flowers have their hands raised.
Tracy, I see yours up first.
Super. Thank you very much. Dr. Tracy Green. I serve as the Chief Medical Officer for the CareSource Nevada Plan, TRACEYGREEN. I am very happy to be here and welcome the Medicaid Advisory Committee and Director Jensen. We are coming to you. We want you all to know that our roadshow begins on Monday morning and CareSource will be in your rural community sometime over the next 4 weeks. We're excited to be traveling with the state joining us in many of the locations. We want you to know that we're also hiring locally. So we will be both in your community and hiring from your community. I'm happy to say that our Nevada team, our goal is to have 100% local to Nevada. Again, I also want to share with you that we will have a QR code that we are working on today that will be an easy way to access all of our current documents, our network, and we will have local provider relations team members in your communities to provide immediate access. So we look forward to multiple times seeing you in your community. We'll have single points of contact, and if possible, we'd like to present even further at the next committee meeting if it's an appropriate agenda topic. So thank you for letting me share a little bit about CareSource today. And as the first and only nonprofit, we know our mission is aligned with your mission, and we look forward to serving the entire state. So thank you.
Thank you, Tracy, for your comment.
Azra here. I'd like to commend Dr. Tracy Green for presenting, and I would like to have both Silver Summit and CareSource be able to be agenda or a topic on our next meeting.
Thank you. Next, JC, I do see your hand up. Go ahead.
Good afternoon. Good afternoon, JC Flowers for the record. Last name Flowers. Work with Nevada Health Centers on the executive side. I want to commend both Silver Summit and CareSource. They've been working very closely with us for the rural expansion. So they've done a really good job, and they're getting information out to us. Director Jensen, this is kind of for you. If we could know ahead of time what communities you're going to, that would be helpful for us. Both Silver Summit and CareSource are doing that as well, if we're not going to be there with them. Because what's happening is what we know will happen is you will go out and present to communities and forums, and then they're going to come to the providers. And since we're in many of the rural areas, we'd like to know when to expect those questions to come in. So if we know you're going to be out there next week, we know next week and the following week, we're going to get a lot of questions. So we can make sure our staff is educated and has the information that they need so that the patients can get that directly from us, whether us having to go back and say, yeah, we'll get back to you on that. So any communication from the state when you all are going out would be very, very helpful.
Yeah. Thank you, JC. Would be happy to do that. I appreciate that suggestion. And we will, our state team that's leading that roadshow on our end, we'll have them connect with you to get you that information for sure.
I appreciate that. Thank you so much. Thanks for the opportunity.
Thanks for being here. It's good to see you.
Thank you, JC. I'm sure one of us have your emails, but if you could possibly throw that in the chat, that would be helpful. Yes, thank you.
No problem. Thank you.
That's all that we have right now. Oh, there's a new hand.
Yeah. I see another hand. Natalie, go ahead.
Hi, this is Natalie Filipic, Filipic, and I'm with Nevada PEP. I'm also a parent and a grandparent of individuals with disabilities and a Medicaid recipient also. My grandson and his services. And I just wanted to thank the committee for including a family voice as a committee member. It's just so important to have that component when making decisions about services and supports for children and families. So thank you so much for including that family voice at the table.
Thank you so much, Natalie, for your comment. I do see one other chat. Nicole, can I also please get in touch with the person leading the roadshow? Yes, Nicole, we will get in touch with you. Thank you for putting your email in there.
Yeah, and Nikki, it's the team that you all have been working with on the implementation side as well. So familiar faces on our managed care team side, and we'll make sure they send that your way. Thank you for that.
Any other public comments? Okay, seeing none, we will go ahead and move on to our next, our final agenda item, which is adjournment. Thank you everyone so much for your participation today. Thank you for making our first official new meeting as the Medicaid Advisory Committee very successful. We really appreciate your time. To all of the back members, all of the providers, administrators, the MCOs, thank you so much for being here. And we will adjourn this meeting. And right now, the time is 2:59 and it is August 13th. Thank you so much, everyone.
Thank you all.
Thank you.
Thank you.